And now the third case, Dr. Alaa Khalid.
Nothing but easy cases.
Good afternoon. My name is Alaa Khalid and I am a neurology resident at Qasr Aini Medical School. Today I'm going to present one of the challenging cases in our department. It is a 23-year-old female patient, single, right-handed, finished the Faculty of Commerce. Family history, she is a daughter of consanguine parent, no history of epilepsy, but there is history of death of two of the brothers. The first one died in the first year due to severe pneumonia, and the second one died at the age of 2.5 years due to affection with meningitis. And we have positive family history of maternal cousin diagnosed with MS at the age of 22. There is unremarkable perinatal or past medical history. The condition started at the age of 1 year when the patient experienced motor clonic seizures, and the patient sought medical advice, and the medication was prescribed in the form of benzodiazepines and sodium valproate with control of seizure from the 4 to 8 years, and the patient becomes seizure-free and stops the anti-seizure medication by herself. Then, by the age of 9, seizure reoccurred, but this time preceded by sensory aura in the form of abnormal sensation in the right side of the back, like an ant walking on her back, and then followed by staring and gestural motor complex and automatism in the form of hand draping, rocking side to side, and paddling and tapping on her lower limb. Such a seizure occurring on daily basis at day and at night, with tending to cluster more at night. And there is no history of status epilepticus. Such a condition was associated with symptoms suggestive of borderline personality disorder. There is a video showing a semiology. There is rocking side to side. Hand draping also present. Also, there is paddling in the lower limbs. And then tapping in her lower limbs. So, seizure type is focal unaware seizure with complex gestural automatism, and the patient on current medications, carbamazepine 800 mg per day, lamotrigine 250 mg per day, and zonisamide 300 mg per day. EEG? Okay.
Can you see the EEG on your screen? Can you see it on your screen?
Yes.
Okay. Her interictals were right temporal, as you can see. Sharp slow waves and also sometimes just slow waves. Her ictal, she recorded 5 seizures, all were the same semiology as presented in the video. This is the onset of the seizures. This is the clinical onset. I was wondering if there was some rephrasm in the right temporal region before she goes into artifact, because she rocks a lot. This is one seizure. Do you want to play? Do you want to see it play? Or this is just the onset, because after that it goes into artifacts. This is another seizure at the onset also. Maybe there's like subtle slow waves in the right temporal region. She has also extrasystoles.
Is the cardiac abnormality found only when she has seizures?
No,
or
no.
Present all the time?
Yes, all the time. This is also another seizure. Following the seizures, she has diffuse slowing. If we are going to, and also can see also these abundant extrasystoles, whether with during or resting, wakefulness and sleep. Um, Regarding the EEG, we see right temporal interictals. There is a possible, maybe possible right temporal onset because it's very brief and it's not really that recruiting, but it's possibly there is something starting in the right temporal region. Do you want to see anything with the EEG or go to imaging?
I'm an MRI person.
Okay.
MS.
Regarding examination, general and neurological examination both are remarkable. Investigation were done in the form of brain MRI with contrast and PET MRI co-registration. The first one was done in 19th of January 2024, shows two lesions, the first one in left amygdala and second one in left frontal. Both of them are of iso to hypometabolism in PET scan. Also, central vein sign was seen, upon which oligoclonal band and IgG index were done, and both are negative. The second set of imaging was done in 19th of July 2024, showing a stationary course of the left amygdala lesion with regression of the left temporal frontal lesion and the presence of new left temporal lesion. Also, third set of MRI was done in 5th of January after the patient received 5 days of pulse steroids in our department, showing a stationary course of 3 lesions, the left frontal, the left temporal, and the left amygdala lesions. This is the 3 MRIs. First one was left amygdala and left frontal. The second one, regression of left frontal and the presence of new left temporal. And the third one showing a stationary course of all the lesions. Other investigations were done in the form of MRI cervical and dorsal with contrast and with normal, pan-CT also with normal. Neuropsychology assessment and cognitive assessment to this patient, the patient of low average IQ 88, affection of domains, a mild affection in attention and affection of language and affection in executive function. So hypothetically, to detect the site of epileptogenesis, regarding semiology, we cannot detect the exact site as it is preceded by subjective sensation followed by gestural motor automatism. Regarding EEG, as Dr. Amani said, it is right temporal in site as a start. Regarding MRI and PET, we have 3 lesions, frontal and the temporal lesion and the amygdala lesion in the left hemisphere. So to sum up, we have a 23-year-old patient with early onset of seizure at the age of 1 year, and it is a single type of semiology occurring at day, at night, and on daily basis, associated with borderline personality disorder. According to EEG, we have a right temporal epileptiform discharge, and according to MRI and PET, we have left temporal lesions. According to our expert opinion, how we explain the new left temporal lesion, and can we consider autoimmune etiology in this case? And is there any surgical plan regarding the left amygdala lesion? It is the only lesion stationary in course in the 3 sets of MRI. Thank you.
Thank you. Could I trouble you to please return to the PET scan? And I trust you don't have the file to go through, do you?
What?
Do you have the file to go through all of the slides?
The MRI unfortunately does a bit.
This is the only image we got.
So I have the MRI is on.
Sure. Was this lesion, this dominant lesion, was it enhancing at the time of this MRI, or was
No.
there no gadolinium?
No enhancement. We did enhancement. We did inject the gadolinium 2 times and no enhancement.
Well, I mean, we're sort of laughing, but not laughing. You know, the imaging is sort of MS typical. I think you have 3 lesions, 2 or 3 lesions, all in the same hemisphere, but that could occur. I think that you said that there were no oligoclonal bands, or
Negative. It was negative.
yeah. So it's difficult because I think with only these lesions and no oligoclonal bands and no cord imaging abnormalities and no real clinical presentation, this would be one which still we wouldn't quite be able to make that diagnosis, but it does have that appearance. And you mentioned you were able to identify a central vein sign in this lesion as well, and its evolution is very typical, I would say, of demyelinating inflammation. So yet again, it raises this possibility. I mentioned MS prodrome, and actually psychiatric conditions have been associated with that, higher utilization for anxiety, depression, and these sorts of things. So I think this could be yet another example of this sort of co-occurrence of epilepsy and MS. Again, the possibility for all these cases that there's just a coincidence, and obviously they were selected to be presented here. But but I do think it just is striking to me that how little I actually see this in clinical practice in the U.S., but where if anything, we're a little bit excessive in the diagnosis of MS. Sometimes in the U.S., people are diagnosed with MS and placed on therapy, which I don't think they have MS. You know, there's almost the move the wrong direction to overdiagnose and get them on treatment quickly.
Mhm.
But by the same token, I almost never see patients with seizures. And here are several patients which smell like multiple sclerosis, but for different reasons are being followed for years without any kind of disease modifying therapy. And they're having these interesting sort of epilepsy presentations. So I don't know, it just seems interesting.
So my question for you, and remind me, when did the first seizures begin, and when did they recur?
The first seizure when in the first year when
Okay.
she is 1. Yeah.
And then they recurred when she was 4 or 5.
The patient became seizure free from the age of 4 to age of 8, and then
Okay.
at the age of 9, recurrence of seizure.
So do you think the seizures between 1 to 5 were the same as the seizures that began at age 8? So do you think she's got the same seizure natural history, or do you think she's got two different seizures syndromes concurrent?
It's hard to identify the first one in the first year, but I think could be difficult.
So again, it would be unusual to have an autoimmune-based epilepsy beginning in the first year of life. I mean, autoimmune diseases, you might be able to see something in the second year of life, but typically you think of it after 3 or 4. So that makes, if it's the same epilepsy, then the issue is epilepsy and the lesions are not relevant. If she really does have paresthesias in her back, then you wonder about a sensory onset in one of 3 sensory areas, which don't go along with the other seizures that you've seen, which look more temporal, for lack of anything else. So, and then for what you've seen is you have right-sided EEG, but you've got left-sided imaging abnormalities. And the PET scan, it's unclear to me whether that's just typical decreased uptake in the temporal lobes or whether it really is down. So one would need to look more closely at those. But assuming she has bilateral temporal hypometabolism, that generally is a poor indicator for long-term surgical outcome, but does not exclude that. So if you are going to think of surgery in this patient, she would need to have stereo EEG to identify the site and location of her foci. But I think the lesions are, as we would say, red herrings. Do you have that expression in Arabic? Red herrings. It's a distraction. It's a diversion. It's not relevant.
I would say if we kind of hone in on what we have right now with the video and the EEG, given especially the various lesions you have on imaging, my first impression when before we got to the imaging, when I was seeing her EEG, was that this is not typical of a temporal lobe onset in my mind. When I saw that EEG, it also wasn't really resounding temporal seizure. I mean, I know you were saying there's a little bit of laterality to the rhythmicity. But I was really struck by how hypermobile she was, by even a little bit, admittedly a little later in the course of the seizure, her legs seemed to move almost like a cycling, pedaling thing. So my sense from just the video was that this was atypical of a real temporal lobe onset. Maybe it could be a rapid spread to frontal areas, or frontal to temporal. So I just would be careful, like, to just hone in on take out her right temporal. I mean, it would definitely, absolutely would need stereo EEG and more. Yeah.
So I have one question. Yes. Okay.
Yeah.
My question: why you put the first possibility that it is MS? I see this lesion is large one. Other MS mimics, you don't think about them. The pathophysiology is inflammatory, I think, because of increasing and decreasing and maybe demyelinating inflammatory. Why we didn't think in other MS mimics in this patient?
So the question was, why not consider other which could be, certainly, and again, I agree with you that this case, the whatever is going on here and the seizure history from infancy probably don't seem super connected. But as a shortcut, if you wanted to evaluate for MOG or NMO or sarcoid, these are reasonable. I think, again, not temporally really connected with the epilepsy, but as a shortcut, sure, I think that would be reasonable to evaluate. I do have to say these do seem very MS typical, though, in terms of their appearance to me. But
Earliest stage of MUG.
oh, well, MOG. Oh, well, actually, I don't know, because you were talking about pushing to like year 2 versus year 1. I think of MOG actually as very common as a source of inflammation in children. I don't know how young that can go. What's the youngest case? We had in the past, we had said that MS can occur in children, and in fact, we thought that MS can even occur in infancy. I think more likely, a lot of those cases, of course, are MOG.
Sorry, I'm a neurosurgeon doing epilepsy surgery. So I came to find a lot of epilepsy cases, surgical cases, but I found a lot of MS cases. So basically, I have another question. If we end up by everything that we have two independent pathologies, okay, MS and epilepsy, and I'm going to do surgery, do you think, because my information about MS is not that good, but do you think surgery by somehow would affect the course of MS for this patient?
It's an excellent question whether if one of these patients has to undergo surgery, would the MS be a factor? I usually separate them. If someone has a need for a surgical procedure, even neurosurgical procedure, I tell them, they always consult me for safety, but I always say I don't think it's a problem. If it is MS, of course, ideally it would be nice if we're controlling the inflammation. But in general, I don't worry about the surgery causing issues. Actually, there's separate literature, which is seizure activity itself, and actually ECT, when that was being used for depression, can increase inflammation and make MS worse. So that's an example where you would want to take care of the epilepsy, whatever it took, properly. But I don't think that there'd be an extra surgical concern, at least in my opinion, because they have MS as a second diagnosis.
So,
But there is a neurosurgical cure for MS.
So may I have a question about the imaging? Yes. So now you can see here, this is a blurring. Yes. What do you suspect? Is this a blurring from a cortical dysplasia or from the ongoing inflammation / demyelination? I don't know.
Yeah, I think we need to look at all the images, and also if that's present on the first MRI. There are things that catch you, and one is we often find dysplasias in the temporal tip of a temporal lobe. So that's why we're focusing on the blurring in the temporal tip whether there's thickening of the cortex, and whether there is blurring between the cortex and the white matter. The other is you can also have subtle malformations, focal cortex dysplasias in the inferior temporal cortex. So you have to look really closely at the ribbon next to and around the hippocampus. And while we rarely see mesial temporal sclerosis in isolation, what I typically see is mesial temporal sclerosis in association with a focal cortex dysplasia. Most common being what would be blurring of the temporal tip, which is typically a type 1 focal cortical dysplasia. Others view that just as hypomyelination, but they don't give an explanation for that. So the challenge here is there's some blurring on the left temporal tip, but there's also a process going on that might be contributing to that blurring. So I think one either has to look at the earlier images or do follow-up imaging to look more closely in that area. I agree with Dr. Ting. I mean, also, it's very unusual to see side-to-side rocking as part of the seizure. So and the bilateral symmetric rubbing of the thighs is also a little bit unusual, but the EEG is compelling. So, so epilepsy it is. The issue is where it's coming from. Temporal is just one area, but this is someone you really need to exclude an insular focus, inferior frontal focus, or a cingulate focus for the epilepsy. And that you can really only do with stereo EEG.
Okay, thank you.
But if you do repeat the MRI and you find the focal cortex dysplasia, then you should take it in.
Thank you, or Professor, thank you, Alaa.